going to do is some accessory movements on the thoracic spine, lumbar spine, cervical spine. This is really developing from the accessory movements you did in the spinal anatomy module. In the thoracic spine, so ideally the patient would have either the top off, or they might be in a vest top, but let's just work with what we have here. So the landmarks for the thoracic spine, so we've got the inferior angle, which would give us the spinous process of T7. The spine and scapula will give us T3. So if I find inferior angle, and then a good thing to do first is to find some spinous processes. They're quite close together, but there is an interspinous space between them. So I think a good thing for you to do first when you practice is finding the spinous processes. Next, if you come out, up, you can find roughly where the transverse processes are. They are difficult to find. And then if you come out further, probably a good 3 inches from the spinous process, further as you go down, you'll find the rib angles. So that's where the rib changes to turn a bit more anterior. So we're going to do some accessory movements on the spinous process. That will be a central PA. The transverse process, which would be a unilateral PA. And on the rib angle, which would be a PA on the rib angle. When you do the spinous process, generally you will use your pisiform. So we'll put the pisiform of the dominant hand on, and then it's 3 fingers in, 2 out. So 3 in, 2 out. It's good to have the plinth nice and low, get some body weight over, and then just see what the movement is like there. And really we're looking for pain. Is there any protective spasm? And does it feel stiff? When you do this and someone is asymptomatic, it should just feel like light pressure. It shouldn't be painful. In the thoracic, it shouldn't feel stiff. And when you do lots of these and lots of people, you'll know what normal should feel like. And also, it shouldn't produce protective muscle spasm, where the muscles around that kind of erector spina tighten up and go into spasm. So let's say on Jake we want to do a grade 3 mobilisation. So pisiform on, 3 in, 2 out, a little bit of body weight over. I'm going to do a nice large range oscillatory movement. Rhythm, about 2 per second. And because you haven't maybe done much of this before, you're going to do it maybe for a minute and then retest. Maybe something in the thoracic like maybe extension, rotation. And we also want to get feedback from the model patient. Is this comfortable? Are you happy with this? Is it producing any symptoms? A grade 4 would be we go to the end of range, come back a bit, small oscillating, end of range, into resistance. I think mostly you'll be doing grade 3. We're then going to come out a little bit laterally. If you're doing the right transverse process or right ribs, it's good to stand on the right side. If you're doing the left, it's good to stand on the left side. So we'll come out, up. I think with the transverse process, it's probably easier to do them with the thumbs. You would do them like that. However, if your thumbs are maybe a little bit uncomfortable with that hypermobile, you can go in with the pisiform like that. That's okay also. So we're just a bit more lateral now, upward, superior on the transverse process. I think what you'll do a lot of in clinical practice is central PAs on the spinous process, and then unilateral on the rib angle. Especially if someone's got maybe some discomfort in breathing, cough, sneeze, lateral pain, pain along the rib. So we could go in, pisiform on the rib. This should feel quite springy, shouldn't be painful, shouldn't be a lot of resistance, shouldn't be any spasm. And we're going to mobilise a big grade 3 large oscillatory movement well into range. If we go down into the lumbar spine, lumbar spine is probably a bit more straightforward. What we will do is some central PAs on the spinous process, some unilateral around the transverse process. Our landmark is top of the iliac crest is L4, pisiform on, 3 into art, pressure or take some body weight across, big grade 3 movement. So this would be a grade 3 central PA on L4 spinous process. We do it on L3. But it's also been aware that you're getting movement in multiple segments when you do this. We also want to then maybe do something where there's more of a unilateral or one-sided problem. So we'll find the spinous process, come out laterally, slightly up, find that with bony resistance, and go in laterally around the transverse process. Difficult to get into the facet joints because they're buried under a lot of muscle. So just to recap, in the thoracic spine we did a central PA with the pisiform and the spinous process, unilateral on the transverse process with thumbs or pisiform, did rib angle with the pisiform, we did a central PA on the spinous process in the lumbar spine, a unilateral on the transverse process in the lumbar spine. And then finally we'll come up to the cervical spine. I think that the accessory that's used here a lot is predominantly either a lateral cervical glide or a unilateral PA. So a unilateral PA, so we'll find the spinous process. I'm on the right side, so I'm going to come out laterally to the right. And I'll be on the articular pillar of that column of facet joints. Thumbs going straight down. Probably tend to do more of a grade 3 oscillatory movement. It's probably hard to see my thumbs, but they're doing that. So really we're asking the patient, is that comfortable? Should be comfortable. The patient sometimes it produces some symptoms. Is there some protective spasm which we shouldn't get? Or does it feel quite stiff? Or maybe it's different. We do it on the right side, feels quite easy. Left side feels stiffer, spasm and pain. And you probably tend to mobilize several levels. You can also do a central PA on the spinous process. Probably not done as much, but in theory you can do that. And then if we get the model on, if we get Jake on his back, I'll just get the pillow again, we can do the lateral glide. This is something that's used a lot. So what we're going to do is an accessory movement, which is a lateral cervical glide. So this is doing an accessory movement in a lateral direction. So what we're going to do is cradle underneath, below the occiput, upper cervical spine with one hand. This point here is going to go in at the articular pillar. And then almost like I'm holding a rugby ball, I'm going to go with the head like that. So it moves across. So we're not doing sine flexion here, we're gliding across. This is to get movements at the facet joints and the intervertebral frame. It's particularly good when you've got someone who's got quite a lot of symptoms, lots of pain, very irritable, easy to flare up. So we're going to go in occiput, This mobilising hand is the articular pillar on the left. And then what I'm going to do is get in nice and close and then move that neck laterally. So we're moving that neck to the right. So it's a nice big grade 3 oscillatory movement. This is something that's relatively challenging to do, so this is something that you'll get practice on a lot, either in this year or in next year, in second year and in third year. And then if we're going to do it to the left side, I'd come on the right. I tend to do it towards the side of symptoms. So I'd come in here, articular pillar, this arm parallel, and glide across. Another accessory move. This is really just used on the very acute necks, means that the recent onset of symptoms or trauma, they're in a lot of pain, a lot of protective muscle spasm. Can't really do a lot else with them. So this is a nice oscillatory movement to do to try and start settling some of that pain, through some of those neurophysiological mechanisms, start to settle some of that muscle spasm, start to introduce a little bit of movement, so then you can do something else. So what we're going to do is some manual cervical traction or an oscillatory longitudinal movement. So one hand below the occiput, upper cervical spine, other hand below that, and then we're going to get in nice and close, and then a little bit of longitudinal traction. Big oscillatory grade 3. And you probably end up doing that for several minutes on an acute neck. Particularly useful when you've got a lot of neck and nerve pain in the arm. Final technique we're going to do in the cervical spine is this is a passive physiological movement. So up to now we've mainly done accessory movements, so this is a physiological movement. So what we're going to do is do some passive side flexion in the neck, which you've done in anatomy, but we're going to do this as a mobilising technique. I think my preference is to do it on a pillow rather than the head suspended over the edge of the bed. So what I'm going to do is one hand below the occiput again, other hand in at the facet joints, and then what we're going to do is do some passive side flexion. So the movement's really coming from my hips and kind of swiveling my hips then. So we're doing, my left hand is towards C2, so that's more passive side flexion, big grade 3 in the upper cervical spine. Whereas if we wanted to do low cervical spine, we would do it lower down. Right, can we just stop the video there?